My name is Sharif Ibrahim. I'm the program manager for the regional EPI program, and this is our Communicable Disease Forum from our regional EPI program and Communicable Disease Service. Welcome, and my apology for the delay and for the technical difficulties. We're trying to solve these issues moving forward. So I want to start by thank you all for your hard work for the last 2 years, and we really appreciate everything you've been doing for public health. And I also want to thank our host, NJDOH, for hosting our webinar and for providing the nursing education credit. Today's webinar will be recorded and posted in our website. The slides and the handout, you can access the slides actually right now in your account at NJLMN by clicking on the library, and you will see the slides in your account. Today, you will get 2.5 public health and nursing credit offered for this webinar. Credits will be provided to those who will attend or who attending the webinar live. You must also complete the two-step registration to get the credits. There is an evaluation link that you will receive immediately after the webinar, and we will also email this link to you in your email provided at NJLMN. You must complete the evaluation immediately after the webinar. We will close the evaluation by Friday, by this coming Friday, the 25th. You must be attending, of course, like I said, attending the webinar live so you can get the credit. I just want to also remind you before we start that next Tuesday, the 29th, we will have another Communicable Disease Forum, and the topic will be focused mainly on the management of COVID outbreaks in post-acute care setting. And this is start at 9:30 to 11:30, and we will be hoping that we avoid the technical difficulties that we have today. So I will let you start with our first presenter, our public health vet, Darby McDermott, and she will present on rabies exposure. I hope you will enjoy the forum today.
Good morning, everyone. Sharif said, my name is Darby McDermott, and I'm the New Jersey State Public Health Veterinarian. I'll be giving an overview on rabies virus, highlighting several human rabies cases in the U.S. in 2021, and discussing a new rabies testing notification requirement in New Jersey. If you have any questions about rabies exposures or investigations in the future, you can always contact the veterinary public health team for assistance. The best phone number to reach us at, as well as my email, is listed on this slide. Rabies is a disease caused by a virus in the Rhabdoviridae family within the genus Lyssavirus. It causes an acute progressive viral encephalomyelitis, and it's most often spread through the bite of an infected animal, but can also be spread through infected saliva or neural tissue such as the brain or spinal cord, entering into a break in the skin or a mucous membrane such as the mouth or eyes. Because the case fatality ratio of rabies infections is almost 100%, rabies is considered the leading viral zoonoses with regard to public health significance. However, the current post-exposure prophylaxis, also known as PEP, available in the U.S., has been nearly 100% effective in preventing illness if it's administered properly and on a timely basis. All mammalian species are susceptible to rabies. There are several distinct variants of rabies virus in the U.S., which are named after their principal reservoir hosts. So the bat variant is present across the United States except in Hawaii, and among terrestrial species, there are skunk, raccoon, and fox variants, along with a mongoose variant in Puerto Rico. The canine variant that is found throughout the world except for Western Europe, Australia, and other island nations was eradicated in North America in 2007 through the implementation of animal control initiatives such as developing an animal vaccine and dog licensing requirements. So looking at the map on this slide, you can see that the raccoon variant is found along the eastern seaboard from Maine to Florida and includes New Jersey. This can result in increased exposures to pets and people because raccoons often live in dense populations near families in suburban environments. In the United States, approximately 5,000 animal rabies cases are reported annually to the CDC, with more than 90% of those cases occurring in wildlife. The number of rabies-related human deaths in the United States declined during the 20th century from more than 100 annually in the early 1900s to just 1 or 2 on average since 1960. And this is due to pet vaccination, the eradication of the canine variant of rabies in the United States, and animal control programs, as well as public health surveillance, testing, and the availability of PEP. So while human cases in the United States have reduced significantly and are relatively rare, in 2021 there was an increase in human rabies cases, with 5 human rabies cases in the United States, 3 of which occurred between September 28th and November 10th, and all 3 of those cases were from bat exposures that occurred in August of 2021. These 3 cases were in Idaho, Illinois, and Texas. One of these patients had submitted the bat responsible for an exposure for testing, but even though that bat was positive for rabies, they refused PEP due to a long-standing fear of vaccines. The other 2 patients did not realize that there was a risk for rabies from their exposures, either because they didn't notice a bite or scratch, or didn't recognize bats as a potential source of rabies. Unfortunately, all 3 of these patients died within 2 to 3 weeks of symptom onset. These cases highlight that even though rabies is relatively rare in humans, it's still a significant risk to people in the US, and it's incredibly important to continue to educate exposed individuals on the risk of rabies as well as the general population so that everyone is aware of this risk. The most common source of human rabies in the US since the 1990s is bats. In a few cases, there was a history of a bat bite, but the majority of cases either had direct contact with a bat but didn't report being bitten, or the nature of that exposure is unknown in those individuals. Persons that are bitten might not realize they were, or they might not consider the bite serious enough to seek medical care. On this slide, you can see the bottom right-hand picture shows a bat bite, and so you can see they're incredibly small, and often, even within a few hours of a bite, you might not see the mark. So even limited or seemingly insignificant physical contact with rabid bats may result in the transmission of rabies virus to humans. The most likely exposure scenario is a person being bitten but being unaware of the bite, or knew that they're bitten but don't seek medical attention. In New Jersey, there have been 2 cases of human rabies from bat exposures. These were in 1997 and 1971. In 1997, a Warren County man died of rabies. There was a history of bats in the home, but there was no reports of the individual being bitten or scratched. But there was a later report that he had removed several bats from his residence using rags over his bare hands to catch them. This was the first human rabies case in New Jersey since 1971, when a person who had been bitten by a rabid bat refused to complete the rabies treatment post-exposure prophylaxis and eventually developed the disease and died. One thing to note is that while bat exposure should be taken seriously and bats can transmit rabies, only a small percentage of bats are infected with rabies. For bats that are submitted for rabies testing, less than 10% are confirmed positive for rabies. And one thing I wanted to point out is that while the canine variant of rabies has been eradicated in the United States since 2007, it still exists and is a threat in other countries, and therefore the risk of reintroduction to the United States exists. Last summer, in June of 2021, a dog in Pennsylvania tested positive for rabies. Testing at the CDC confirmed that the dog had been infected with a canine variant of rabies. And this dog had been among a group of 33 dogs and one cat that were imported from Azerbaijan. The animals had been distributed to multiple states, and one of the dogs in this transport did come to New Jersey. All of these animals were considered potentially exposed to the rabid dog, and serologic testing was done to determine whether these animals were previously vaccinated against rabies to determine the need for observation periods. This work was done not only to follow up on the immediate known exposures to rabies, but also to make sure that the canine variant of rabies didn't continue on and infect other animals in the United States. On this slide, you can see a summary of the rabies specimens tested at the New Jersey Rabies Laboratory from 2018 to 2021. In recent years, we've had around 200 to 300 animals test positive for rabies annually. The vast majority of these cases are in wild animals. It's important to note that in New Jersey, cats have accounted for 91% of the domestic animal cases since 1989. For the last 5 years, there's been an average of 17 cats infected with rabies annually. More detailed information about the rabies statistics can be found on the New Jersey Department of Health Communicable Disease webpage. Local health departments play a crucial role in preventing cases of rabies in humans and domestic animals. That role includes receiving reports of confirmed or possible exposures of humans or domestic animals to rabies, investigating those exposures, initiating confinement and observation of dogs, cats, or ferrets that bite people, determining if rabies testing of an animal is necessary, and if it is, whether that animal is available for testing, and if so, coordinating testing at the rabies lab. Local health departments also educate exposed individuals on rabies, advise them of the PEP protocols, and to seek care from a healthcare provider when indicated. And they also receive information on post-exposure prophylaxis from healthcare providers on CDC forms. The Department of Health has many resources that you can review on our rabies webpage. A couple of resources I'd like to highlight in particular include the New Jersey Guide to Rabies Post-Exposure Prophylaxis, as well as the Management of Domestic Animal Rabies Exposures documents. Both of these can be found on the disease prevention topic and can walk through how to handle different exposures in people or domestic animals. There are also guidelines for lab packaging and transport and different educational materials on this webpage. Lastly, I'd like to discuss a new requirement for rabies testing in New Jersey. On January 18th of this year, Bill A1219 was signed into law by the governor. This bill requires that when an owned domestic companion animal needs to be tested for rabies, the health official requiring the testing or the veterinarian preparing the specimen for testing must notify the owner both verbally and in writing of the necessity for rabies testing, as well as the rabies testing protocol to be followed, which would include the protocol of decapitation and any protocol for disposal of the animal's remains. The owner is to immediately provide release of the animal and a signature to acknowledge notification of the protocols and procedures to be followed. In instances where the health official or veterinarian have made reasonable attempts to notify the owner and the owner is either unable to be contacted or a signature is unable to be provided, rabies testing can still proceed. When contact is made but a written signature is not obtained, the vet or health official must document the date and time of that verbal notification and keep this record on file for at least 6 months. One other thing to note is that livestock is not included in domestic companion animals. This bill requires that the New Jersey Department of Health develops a form for health officials and veterinarians to use to provide this notification about the protocols and procedures to be followed, and to post this form online. We are currently in the process of developing and finalizing this form. So once it is finalized, we will post it on our New Jersey Department of Health rabies webpage, and we'll be sure to send out notifications to all of the local health departments to make them aware that this form is available and should be used to meet the new requirements. Thank you very much.
Next speaker, please.
Malothy, I think you're muted.
Can you hear me now?
Yes, go ahead.
Hello?
Yes,
Okay.
yes. Can you speak up? You're a little faint.
Now?
You're good. You're good.
Actually, there are 12 presenters for this presentation, so they are muted. I don't know if you can unmute them, but I can start the presentation. Good morning, everyone. I'm Malati Arkoti. I work for New Jersey Department of Health as Health Data Specialist. Thank you for giving me this opportunity to present on some new updates and 2 new programs in Epicenter. Before I start, I would like to have few acknowledgements. Thank you, Stella, for your support and your encouragement throughout. And thank you, Sherry, for accommodating us to present today and helping me to get through this process. Here is the overview of the presentation. I know why it's looking like that, but I'll go over the Epicenter updates. There are 2 new programs called SOAP, which is Suspected Overdoses Alerting Program, and the 2 new dashboards in Epicenter. Nanan will go over the summary report. I don't know if she can unmute herself. And Kena will describe the DUA process, and I'll go over the public health uses of the Epicenter data at the end. Little background on Epicenter. Epicenter is a New Jersey Department of Health syndromic surveillance system used for monitoring emergency department visits that collects de-identified patient-level visit information, including date and time of the visit, basic demographics of the patient, and the chief complaint or the reason for patient visits. Most of the facilities, that's 79 of the 80 emergency departments, are connected with data through emergency departments information systems that goes directly to Epicenter in near real time. Counties have access to Epicenter to monitor activities, and counties and facilities can sign up to see their own data. The chief complaint field is the basis for the analysis in Epicenter. These visits are categorized into classifications like respiratory or GI or overdoses, and there are classifications within the system. And Epicenter also have the capability for creating custom classifiers if needed, but with some limitations. Training will be provided to those who are interested in using Epicenter, and the webinar is already available if anyone wants to learn more about Epicenter in detail. Data use agreement is required to access the data in Epicenter. Hopefully, Kenna will go over that shortly. This is a slide which is showing one of the features of Epicenter that is useful to local health departments. As you may see, there are some tabs on the tab here, and each tab has specific functionalities. This is a sample from the charts tab. You can use data to generate charts and drill down into granular bits of it. You can pull data for a jurisdiction either by a county level or go down to facility or zip code level over a time period, which is shown in red here. And you can also choose to look at total counts over time or at some specific symptoms or syndromes, depending on what you're looking for, which is circled in yellow here. You can select more options from here and filter them as per your requirement. And when you submit, you'll generate Epicenter will generate a graph. When you double click the graph, a larger version of it is seen. And there's a tab for patients. So you can use the additional tab patients to actually look at the individual patients that make up the chart that you pulled. Epicenter has New Jersey opioid-related classifiers, which are classified into 4 groups: suspected drug overdoses, suspected overdoses involving opioids, suspected overdoses involving heroin, and suspected overdoses involving stimulants. When you download the data from Epicenter for these classifiers, the data will include these variables in your report, which can be used for further analysis. Data is not limited to overdoses. Other chief complaints may include COVID-19, heat-related, ILI, carbon monoxide, and so on. The two new programs that I want to highlight today are, one of them is a SOAP, or Suspected Overdoses Alerting Program. Epicenter have the capability to send email alerts on suspected overdoses for local health department users who are interested in drug overdoses in their community. This can be automated so that Epicenter sends the email when an overdose exceeds the set threshold levels. The overdoses are classified into four classifications, as I mentioned in the previous slide. Suspected all drug overdoses, suspected opioid overdoses, suspected heroin and stimulant overdoses. For this program, we piloted 3 counties, Atlantic, Camden, and Ocean, and 7 other counties signed up to receive the email alerts and training on overdose dashboard. Thresholds were calculated by taking the daily average overdoses by county for 1 year. We used 2020 year here, and we did the same for all categories by county. It's a constant threshold that was set for each county and by each classification. Thresholds can also be customized by local health departments if needed. A training was provided to the pilot counties on Epicenter, and these counties receive email alerts from Epicenter whenever an overdose exceeds the set threshold levels. After providing the training on overdose dashboard in Epicenter, we follow up after a few months with the local health departments by administering a survey, which helps us to understand how they're using these 2 systems and how these 2 systems are helpful to them. The second program in the Epicenter that's new and I want to highlight today is the dashboard. There are 2 different dashboards, COVID-19 and overdose data dashboard. These dashboards are very simple to use and helps in understanding the overdose trends in the county or the state. You can filter the data by county, zip code, facility, demographic variables, or by overdose classification itself. When counties or alleged local health departments sign up for these 2 programs, in Epicenter, training will be provided in detail. This is a sample email that looks like when an overdose exceeds the set threshold level. You can see the time of anomaly, time detected, location, the threshold value that's set, and the interactions that have exceeded the set threshold level. If you want to investigate the anomaly, you can click on this link here, which takes you directly to the Epicenter, and you can find out more information on that. If you want patient level details, you can also download it from here in Excel. I will pass over to Nanan to present the weekly summary report. I'm not sure if she can unmute herself. Nanan, are you able to unmute yourself?
I don't think she will be able to, so I would continue in her behalf.
Okay, so this is a weekly summary report, so I'm not sure. I'll just go over, I don't know exactly about this, but here are the chief complaints. These are some of the few chief complaints. So if there's a detailed report, but I'm showing just few of them here. And it also have the location, the county, and new outcome, new investigation outcome, or the intermediate, which I'm not sure about the definitions, but here are the total cases that you can see, and this is generated every week by MMWR week. So you can request for this summary report as well. For the user agreements, there are 2 different user agreements. You can reach out to Kenna if you want to access the Epicenter, or email is provided. There are 2 different types of user agreements, one for local health department and one for facility or hospital users. You have to specify which of these categories you're in when requesting the form. And at this time, we are not granting access to users outside of these 2 categories. Kena have included instructions for filling out the user agreements in this slide. For local health department users, it's a 2-page form which needs to be filled with the user's personal information such as title, email, etc., and signed off on by the health officer and then returned to Kena via email for the last section and to be sent to HMS for access. If there are already existing epicenter users at your organization and your access can be modeled after this, please include their name as well. Also specify reports or dashboards you would need to access, such as the opioid dashboard. For hospital users, agreements can be sent to HMS and not to New Jersey Department of Health. Some of the public health uses of epicenter data are you can download the reports for a time period and analyze the data by county, facility, or zip codes for any chief complaints. Data or charts can be used to monitor the trends of various chief complaints. Prepare summary reports, use the charts for presentations, investigate the anomalies and find the clusters or outbreaks in your community. Use the data to prepare response protocols, and also share or present the information to other local stakeholders or community partners. Here are some of the DOH contacts. For epicenter training, you can reach out to me or Stella. For data use agreement, you can reach out to Kena Patel. For summary report and for anomaly reports, you can reach out to Nanan or NJDOH surveillance. For any functional or user login issues, you can reach out to HMS directly at Emily or to Emily or Joel Panaro. You can email them. Thank you for listening to the presentation. Open for questions now.
So question will be at the end of the webinar. So please, next speaker. Thank you.
Good morning, I'm Sarah Leifer. I just wanted to spend a moment introducing the DISH team before I start. We're a fairly new team at the Communicable Disease Service, and we focus on schools, daycares, and institutes of higher ed. Our mission is to prioritize collaboration, education, and training that strengthens public health and minimizes infectious disease transmission in these settings, in the daycares, in the schools, and in the institutes of higher ed. Some of the proactive activities that we engage in include creating and disseminating trainings for these settings and trying to identify and address barriers in these educational settings. In certain instances, we can also support the local health department and the regional epidemiologists with surveillance and outbreak response. Just want to introduce ourselves. We're a small team. Right now, we're 3 epidemiologists and 1 nursing consultant. You'll see our names on the screen. Victoria Simpson is the epi on our team that covers the north for DISH. Tasnim covered the central region, and I'm Sarah. I cover the southern region. And Stacy DeFrank is our nursing consultant. She actually has been a school nurse for years herself, and she is supporting us statewide at this time. A little bit about how many of these types of settings we have in the state. DISH statistics, we have 123 institutes of higher ed, and that includes colleges, universities, community colleges, trade schools, 689 school districts, and over 3,600 schools between public schools and private schools. We have a little bit more information here on child cares. We got a little bit more detailed here. According to DCF, there are close to 4,000 licensed child cares in the state. We broke it down by county for you here, and you'll notice that many of the counties in the northern part of the state really have quite a few child care centers, licensed child care centers in them. We decided to focus on child care centers in our initial activities because we figured the K-12 schools often have a school nurse, the institutes of higher ed often have a health center. It kind of felt like maybe the child cares needed a little bit more attention for that reason. And over here you see the distribution of child cares in the state. Similar to what you saw in the list on in the prior slide, you'll see that there's a lot of blue in the northern part of the state, especially the northeast. There's just a lot of child care centers up there in those counties in the northeastern part of the state. A little bit about historic childcare outbreaks, so what we've been seeing for the past few years in terms of reported outbreaks in childcares. If you go back, this is looking at reported outbreaks from 2016 through 2021. If you go back to 2016, you'll see that it was a bad year for hand, foot, and mouth disease. That's the orange bar. 2021 also had a lot of hand, foot, and mouth disease. The flu, of course, always fluctuates. So you'll see that that's what we have that represented in yellow. So you'll see 2019 was a pretty bad year for the flu. Notice a complete absence of the flu in 2021. There's no yellow there at all, which we know, and we know that there really wasn't any flu in 2021. We remember that RSV was high in the end of the summer and the fall of 2021, and sure enough, we see that in the blue in 2021. The blue bar represents the number of RSV outbreaks, and then of course green must represent COVID, and indeed it does. There was no COVID before 2020, and of course the preponderance of outbreaks in recent years have been COVID outbreaks. So in 2021 we had close to 300 COVID outbreaks reported in childcare statewide. And this slide demonstrates the variation in reporting across the state. So this shows the number of outbreaks per the number of childcares in each local health department's jurisdiction. Each point on this graph represents one local health department, and what we're measuring is the number of reported outbreaks from when the pandemic began through October of 2021. So some local health departments, the points towards the top of the graph, may have as many as 5 or 6 reported outbreaks in that time frame for every 10 childcares in their jurisdiction, while others may have as few as 0 reported outbreaks. One factor that may be at play here is the number of childcares in the jurisdiction. So when there are very few childcares in a jurisdiction, it's obviously easier to keep up a relationship with them. You'll notice that many of the local health departments whose child care centers do a lot of reporting have fewer centers within their jurisdiction. They'll be further to the left on this graph. However, it's obviously not the only factor, as many of the local health departments who have fewer reported outbreaks also have few centers in their jurisdiction. Part of what we're trying to do, what the DISH team is trying to do, though, is to try to make child care centers more familiar with outbreak protocols and how to report and who to report to. Since COVID, the notion of reporting outbreaks has definitely been brought to the forefront in this population. So we think it's a possibility that over the coming months and years, this graph will start looking a little bit less variable. Again, to try to build awareness, what we started by doing is to reach out to some of the child care centers through the local health departments with a survey that was designed to assess their training needs. And Victoria is going to talk a little bit about what that survey found.
Hello, this is Victoria Simpson. I'm one of the epidemiologists from the DISH team. So the DISH team did pilot a child care survey with 1/3 of the state in the northern region of New Jersey during December of 2021, and we're going to take this time to share some of those aggregate results with you. So each local health department that participates in our survey will receive individualized survey results so they can understand the needs of the child care centers within their jurisdiction. Additionally, though the results we are going to be talking about today is not comprehensive of the entire state, the DISH team is currently meeting with local health departments in the central and southern parts of New Jersey to move forward with this survey statewide. So you may have an email from us if you're from the central or southern parts asking to meet with us so we can talk about this survey. And of course, if you have further questions about how this survey will be initiated in your jurisdiction, please reach out to a DISH team member. So on your screen right now, you can see the response rates for the Northern Pilot Survey for child care centers. So this pilot did include all local health departments in Warren, Sussex, Morris, Union, Essex, Bergen, Hudson, and Passaic County. You'll notice that there is some Somerset County percentages on the screen, and that's just because one local health department does service child care centers in both Morris County and Somerset County. So though it looks like Somerset has the lowest response rate at 33.33% right now, we do expect that to increase when we get to survey all the child care centers in Somerset County. So the overall response rate for the survey with our pilot was 40.5%. So the survey was sent to 803 emails in total so far with our pilot. And Warren County did have the highest response rate for our pilot survey at 57.14%. And you can see that those percentage and response rate varies. Passaic had a 34.69%, and you can see the others on our screen as well as through the individualized results that you should have received through your email if you participated already. And so there were 731 child care centers that participated in the survey, and these child care centers serviced approximately 52,230 children with 12,325 staff members. So the mission statement of the DISH team is to prioritize education, collaboration, and training in educational settings. Therefore, we did have a survey question that asked child care centers to indicate the trainings that they thought their team would benefit from. You can see now that general outbreak training was requested the most from the cumulative survey results. And since we received these results from the pilot survey, the DISH team has recorded a short general outbreak training for local health departments that you can send to your child care centers. And that training can be found on the education and training page. So if you have not yet sent that training to your child care centers, please feel free to do so. Additionally, you can see hand, foot, and mouth disease was the second requested training, and the DISH team is currently working on getting that one finalized so we can send that one out. And then thirdly, they asked for training on COVID-19. So we do have a pre-recorded webinar called Best Practices for Child Care Centers in the COVID-19 era that is available for local health departments to send to their child care centers as well. And that's also located on the education and training page. And then on the graph, you can see that they did request other things as well, like RSV, the flu, benefits of vaccination, cohorting, GI illness. So the DISH team is continuously working on additional resources based on the request from this survey so that we can send them out to child care centers. Additionally, the survey asked the child care centers how often they would like to receive these materials and education from New Jersey Department of Health, and around 52% of the child care centers voted for monthly communication. And the child care centers would like to see the communication in the form of one-page fact sheets via email, guidance documents, and then pre-recorded webinars. And then the survey also asked child care centers if they have ever consulted with their local health departments regarding an infectious disease at their child care center. And please note that several child care centers said that they have not yet consulted with their local health departments regarding an infectious disease. So approximately 28.2% had not yet worked with their local health department. So local health departments who have already participated in this Northern Pilot survey should have received their individualized results from a DISH team member through email so they can see if they do have facilities who have not yet worked with them. And so for those facilities, we encourage local health departments to make sure they're including them in their emails that are sent out with infectious disease resources and updates. And of course, 71.8% of the child care centers are continuously working with their local health departments. And then additionally, out of the 731 child care centers who participated in the survey, 597 of them said that they received updates from their local health departments with COVID-19 information. 419 received general infectious disease information. 225 received links messages. And then 127 child care centers indicated that they have not received any of that information as of yet. And then the survey just ended with an open-ended question that asked them if there was anything else they wanted to tell New Jersey Department of Health. And if you see the slide right now, you can tell from the survey comments how appreciative the child care centers are of the work that local health departments have done during the pandemic. So several of the local health departments were actually mentioned by name and just giving them thanks for all the work you guys have done. And so the DISH team just wants to thank you as well for the work that you've done to benefit daycare schools and of course, institutes of higher education. So moving forward, the DISH team will continue to send local health departments resources regularly to forward onto their child care centers and schools. We're hopeful that our resources will facilitate increased communication between local health departments and the child care centers and schools in your jurisdiction for proactive management of infectious diseases. So some additional resources that we have made that we've not yet mentioned do include a short webinar on how to navigate the CDS website for schools and child care centers, as well as how to fill out a COVID-19 outbreak line list properly. And we also have some pre-recorded trainings that go over some updates for the guidance for New Jersey Department of Health guidance documents. So all of our resources do live on the education and training page. So that's just a good place to check regularly for new materials that we might create. And then if you have requests for training or any questions, you can always feel free to reach out to a DISH team member. And then the email that you see on your screen right now, the cds.rep.communications@doh.nj.gov, is our shared email account. So if you have any questions or concerns, you can always reach us there. And that's all I have for today. I think now Kim is going to be speaking next.
Thank you, Victoria. I'm not sure, Ryan, before the program update, can we go back to the first slides and the first presentations, if that's possible? Thank you, sir. So that's vaccine preventable disease, Liz.
Good morning. While Ryan's getting to the slides, can somebody confirm that you can hear me, please?
Yes, we can.
Okay, thank you so much. Oops. Okay. Good morning, everybody. So obviously we had some technical difficulties this morning. I apologize, and I am going to try to talk as coherently as possible. So please bear with me. I also am a very fast talker, and I do have a lot to tell you. I'm going to go through the slides pretty quickly, but I do plan on sending out some information after, and you're always welcome to give me a call if you have any questions, and I'd be happy to answer questions at the end of the session today. So my name is Elizabeth Zaremski, and I am the surveillance coordinator for the Vaccine Preventable Disease Program at New Jersey Department of Health. And today I just wanted to go over some information about case investigation for vaccine preventable diseases. It's been a while since we've talked to all of you folks, and I know that there's a lot of new individuals working on case investigations. So we just kind of wanted to do an overall session about some of the expectations that we have as far as VPD case investigations and some of the resources that are available to you. And then in future sessions, we'd be happy to delve into disease-specific presentations. This was intended to be one of the first presentations that you saw today, so some of the information may have been touched on. I also was not able to log in at the beginning, so I may have missed some of the things that were talked about. But I just wanted to let you know that if you haven't yet already visited our Communicable Disease Service page, you should do so, because there's a lot of great information available to you. I encourage you to take a look and become familiar with it. On this page, you can find information about how to report disease, and information about the regulations, New Jersey Administrative Code. You can actually access the code so you can see what is required. You have access to all of the reporting requirements and resources associated with that, information about HIPAA, disease statistics, and then you can also access disease-specific pages. You may hear us talk about the magnet, and this is what it looks like. Many of you may be familiar with this and remember back when we actually had a large magnet that was distributed, that folks could post in different places that were easily accessible so that they were able to quickly review what was immediately reportable versus reportable in 24 hours. This magnet is still available in paper form for download on our website. It is a great resource. It is still listed as July 2013, but they are still current as of now. We are working on updating regulations, but it'll probably be a while before those regulations go into effect. I apologize, I forgot to change the slide. This is the magnet. Okay. So now I want to go into a little bit of information about case investigation and just quickly review some of the process that we kind of expect as it goes, as you go through a case investigation. So this may actually apply to some of the diseases that you investigate outside of vaccine preventable diseases as well. So it should be applicable across the board to many things that you work on. One of the very first things that's important is to consider case assessment when you first get a case in CDRSS, it's really important to take a look at the case and understand what exactly it is you are investigating. For example, if it comes in via ELR, open up that laboratory result and see what the lab was that was reported to you and what does that lab mean for the disease that you're investigating. Was this case correctly reported and requires public health follow-up, or is it possible that the case was reported in error? For example, maybe something collected from a non-sterile site that's actually not reportable for Haemophilus influenzae or, Neisseria meningitidis. So it's really important that you understand what it is that you're going to be investigating before you actually jump into a case investigation. Also, if you get a verbal report of a disease, you want to verify what the person that's reporting it to you is actually reporting. For example, if they say that they're reporting meningitis, are they actually reporting Neisseria meningitidis, which is also invasive meningococcal disease, and that does require immediate public health response? Or are they reporting meningitis, which is actually a symptom and may or may not be reportable depending on what the cause of the meningitis is? There's a lot of different things that can cause meningitis. Some are reportable and some are not. So it's very important that before you launch into a case investigation, that you understand what it is you're reporting before you waste time and energy on doing something. Another important piece is to become familiar with the disease and the available resources. You might want to take a look at the CDRSS disease module, see what kind of signs and symptoms, risk factors, other pieces of information are listed in the case before you launch into an interview. Take a look at our disease specific page, and look at the chapters and the toolkits that are available to you. Those can help you as you proceed with your case investigation. We have lots of resources, and we do try to keep them up to date. Some are not, and of course with COVID, as just like everybody else, we're behind on perhaps reviewing and updating, but there is still some very, very good information, and we do try to date that information so that you know how current it really is, and you can always give us a call. Interviewing is an integral part of case investigation. This is really, really important to collect as much information as possible to better assess what's happening with this particular case. It's certainly perfectly acceptable to start with interviewing a provider to inquire why a test was ordered and to collect the initial clinical information. But it's also really important for a case to be interviewed. The provider only sees a person for a snapshot in time, but your case may actually have a lot other important information which would be pertinent to your case investigation. So don't just rely on what the provider is telling you and then close out the case. It's really important to call that person that was reported to you with a communicable disease and do an interview with them. This is public health, and so talking to the public is really, really important. And a second part of that is also with, we're trying to prevent the spread of disease. So it's really important to talk to that individual to identify close contacts that might need some sort of follow-up. Sometimes it's important to interview family members or friends in order to get important public health details. The individual that you may be interviewing may be very, very ill and not able to communicate with you at the time. And so in some circumstances, for example, meningococcal disease, if the individual may be intubated, you may need to interview their family members and friends to start with getting important information such as onset dates, which affects the public health response, and to begin to identify close contacts. You would circle back to the individual when they're well enough to interview to verify those details. But sometimes it's important to interview other folks besides the case in order to start with public health response. I tend to look at case investigation as sort of 3 parts, but they have some overlap. They work together, and it sort of affects the information that you're collecting. I sort of look at the initial report as how you determine whether or not to proceed or how to proceed with your case investigation. And then you have the actual public health response. What are you doing with the individual that you're investigating? Are you isolating them? Are you making sure that they have treatment? And then you need to follow up with the close contacts and ensure that they are taken care of appropriately. Excuse me. And then the third part is the data entry and the case classification. So while those pieces go together, you often need different pieces of information for each of those 3 parts. And for us, not everything is black and white, and we may ask you for additional information that will help us make a determination as to how to proceed when you're doing your case assessment and whether or not you can cease follow-up. Sometimes if there's a suspect measles case, we may ask you for what might appear to be unnecessary information, but it may help us decide whether or not we actually think it's a measles case and that you should proceed with launching a full public health response, or whether you can stop doing the case and it's likely not a measles case and we can close that out and you can move on to the next thing on your to-do list. During your response, you may also provide exclusion or isolation guidance. You'll need to identify your close contacts of the case and possibly issue exposure notifications and recommend those contacts maybe for prophylaxis. And then you want to follow up with those contacts at the end of an incubation period to see if any additional cases have occurred. So you're not just investigating a single case in a vacuum, you're trying to prevent the spread of disease and know whether or not that one case, actually turned into a handful of other cases. Some tips that we have for you guys as you approach case investigations and working with your jurisdictions, it's definitely beneficial to, if you haven't already, to establish some relationships with your school nurses and the local providers or facilities. Get to know them, have them get to know you, so that it can make things more efficient when you give them a call when you have a case that you're investigating and that you're working on. You want them to be able to reach out to you also if they have an issue before it turns into something that's bigger. And together you can find ways that, you can make sure that your communications are more efficient. Do you work better with phone calls? Do you work better with emails? So it's definitely a good idea to establish relationships with the folks in your jurisdiction. And it's also important to get to know the regional EPIs that are assigned to your jurisdiction, as well as the subject matter experts. We're all here to help you, and we love our jobs, and we are happy to provide guidance. So, get to know us. We're not scary. We don't bite, and we're happy to help. We'd rather have you do something the right way one time without you wasting resources. We know you're all very busy and drowning right now, especially with COVID. And so we'd rather have you spend a couple minutes with us on the phone and not have to redo some extra work. So give us a call, get to know us. When you're doing an interview, it really is important to be comfortable with HIPAA. A lot of places, I'm sure many of you have come across this, you call a provider office or you call a patient and they cite HIPAA. They incorrectly cite HIPAA. And then they refuse to provide you the information that you need in order to proceed with the case investigation. Be comfortable with it and be prepared to provide, correct information and documentation if you need to. Some provider offices request something in writing. So be comfortable with that before you start, making your phone calls. Feel free to inform the provider that you're talking to, that you're going to be reaching out to their patients. Most providers don't mind, and some others may actually want to talk to their patient before you give them a call. So give them a chance to do that. You can just simply say to them something like, "No problem, Dr. Smith, I'll wait a little bit and let you reach out to the patient first, and then I'm going to give them a call around 3 o'clock. Does that sound reasonable to you?" But you also don't have to wait for a provider. I know a lot of times these providers don't answer the phone, they don't come back to you, they don't call you back, and they don't send you any information. If that happens, you should still proceed and reach out to the case to find out what's happening and why the test was ordered if they're symptomatic. If you are talking to the case, you can let the case know that if you have spoken to the provider, that the provider does know that you're calling. It's part of public health response. Sometimes that helps, open the door to talking to an individual about their situation. When you're interviewing with the patient, I find that open-ended questions are helpful. For example, we have a lot of questions about the rash when we're doing a measles case investigation. So it may be helpful to say to them something like, can you please tell me what the rash looked like? Where did you start with it first? And where did it go next? And how does it look now? Is it itchy? And let them talk to you about it. Have them tell you a story about, the symptom progression. It's also really helpful to use a calendar or prompts. For example, if you're doing pertussis, ask the individual, do you remember when your cough started? Did it start around a holiday or a birthday? Often with pertussis, they've been coughing for weeks. So it's important to sort of try to get them to associate it with something else, and have them pull out a calendar and look at it. You may not get an exact onset date, but as close to as possible as you can get to narrowing it down to an onset date is very, very helpful, because those onset dates are often important in determining the infectious period and then the incubation period. Definitely leave the door open. You know, a lot of times, you guys will call us and talk to us, and we'll say to you, well, what about this? And what about that? And what about the third thing? And you're going to need to call the patient back to ask them some more questions. It's definitely helpful to do that up front. And you can say that. You can say, you know what, I'm going to review this with some of the subject matter experts. I may have additional questions. Would it be right if I gave you a call back? And what's the best way to reach you? If you have gotten all the information that you need, it definitely would be helpful to say to them, you know, hey, I'm going to give you a call in a couple of weeks just to see how you're doing and see if anybody else became ill. That would be around the week of March 28th. Is there a better day of the week to reach you, or is this the best number to reach you? This way that they know that you're gonna be calling them back, and what the expectation is from them. And this way you can also give them an opportunity to tell you how best it is for them to get in contact with them, excuse me. We often see things in cases about patients being unreachable, and this does happen, but we do request that you try many, many different approaches before you consider the person unreachable. Talk to the provider and see if the provider has additional contact information. Maybe they have additional phone number. You can send them a letter. Try an internet search. Do a reverse search on their address or a reverse search on their phone number. You can try their name. NJDOH is a great resource. Many, many, many more children and young adults are in NJDOH right now. So it's definitely a good resource to verify their phone numbers. Sometimes you just have an inverted telephone number and a couple of digits are inverted, and you might be able to get a good phone number and be able to reach that individual. Okay. Let's see. Sorry, I thought I forgot to switch slides. I did not. Okay. Exposure notifications. In a lot of our case investigations, you will need to do some exposure notifications. It's really important to first verify that an exposure actually occurred before issuing notifications. Determine the potential exposure dates and the incubation periods, and verify that an individual that was ill and infectious was actually, for example, in school while infectious before sending out any kind of notifications and potentially panicking people. You want to work with the facilities that you're going to be sending out exposure notifications for. For example, schools. If they're going to be sending out a communication, see if you can get them to give you a copy of that communication, not to rip it to shreds or anything like that, but just to make sure that there's no inaccuracies. And then you can provide a copy to us so that we're all aware of what's going out. It's helpful to know when it's going out and the method by which it's going out. Are they sending home letters? Are they sending out emails? This way we're all aware of what is being communicated. We often talk about one voice, one message. We want to make sure that we're all on the same page before issuing messaging in order to be able to prevent confusion and some panic. Sometimes taking a couple of minutes up front can prevent a lot of grief on the back end. A lot of our diseases do have template exposure notification letters available for use, and you can give us a call. Some are available on the website and some are available upon request if you give us a call or send us an email. Many people don't realize that you can set up email notifications in CDRSS. You can just go to your left-hand navigation bar, click on personalize, and then click on email notifications, and you can set that up. I have that set up to give me notifications whenever measles cases are created, any of the immediately reportable diseases. That way I get an email right away when a case is created. That's a great tool to use so that you know what's coming in, especially if you're working on, maybe it's not immediately reportable, but you're working on an outbreak of pertussis or, pertussis is immediately reportable, but like say mumps, you're working on an outbreak of mumps. You may want to turn on the email notification temporarily so that you know if any cases come up in your jurisdiction so you can keep an eye on that. It's a great tool. Back a few years ago, the Communicable Disease Service developed this guidance document called Disease Prioritization for Investigation and Response Guidance. It was distributed via NJ Links in March of 2018, and I know it's been continued to be shared by the Regional EPI program. It was provided as a guide to help local health departments further prioritize public health investigation and response beyond what's actually currently listed in regulation. It gives you some timeframes for critical actions and documenting that information in cases, which can vary greatly by disease. And so it was intended to sort of help you better prioritize, especially with like reduced resources and increased workload. It's a really great resource. And I know even though Sharif and his crew have been sending it out, I also plan to get the attendee list and send out that document to you folks, as well as some additional notes that I wanted to share with you. Okay. So I mentioned earlier about 3 parts to, what I consider a case investigation. And the third part is data entry and case classification. Documentation in CDRSS is really an important communication tool with the regional EPI program and the subject matter experts. It lets us know where you are in a case investigation without always having to call you or email you. But it's not usually very necessary to write huge paragraphs or copy large chunks of a medical record into a case. Many very complete cases actually have very few comments, but they have all of the necessary and important critical variables completed in the case. For example, signs and symptoms. You don't necessarily have to write out a paragraph of the signs and symptoms. You should be able to go to the signs and symptoms section and check off yes or no, whether the individual has them. And then you can put some extra information that you feel is important into comments. But as long as the data elements are entered in the different sections, you actually can have a very, very thorough and complete case investigation without having a lot of written communication. Also, please note, it's really important that data is put into the specific data fields, because if not, it's not exportable for us. We can pull comments out of the case, but it is very difficult and time consuming, and it's extremely difficult to analyze that information when the data is needed. So when possible, please put that information into the specific data fields. It makes it much easier to review the cases as well as to export and analyze the data. Some of the elements that are requested are actually required by the New Jersey Administrative Code. For example, race and ethnicity. That's something that people don't realize is actually something that is technically considered required. So it is important to try to fill out those elements. Other things like cough duration are elements that are important for helping us determine case classification. And then an additional set of data elements may actually seem unimportant for public health response, but may be required of us by CDC or a deliverable for our grants. And so we request that information so that we can supply that to CDC to satisfy our requirement to them. And oftentimes, if that information isn't in the standard sections, it will be in what's called the disease-specific questionnaire, or DSQ. And we also may ask you additional questions. For example, like in a meningococcal case, you'll see us send us a separate email with a couple of additional questions. That actually gets added into a meningococcal spreadsheet that we send to CDC. So oftentimes when we're asking you for additional information, it's because we actually do need it. So these are the sections that are in CDRSS that are important. I just want to expand on that just a little bit, and I'm not sure how I'm doing on time, so I'm gonna probably speed up my communication here. Okay, so illness onset, again, I mentioned this earlier, is extremely important for us. Please complete that. That helps us determine the infectious period, and that then further dictates the public health response and actions that may be necessary. It's always a good idea to verify the demographics, make sure you have the spelling of the name correct, and the date of birth is accurate, as well as the contact information. I mentioned signs and symptoms, very important for us in order to be able to determine case classification. Use of asymptomatic is acceptable. If an individual, was tested to check for immunity, asymptomatic may not actually be listed, but you can add it to the case, and that's helpful for us. Pregnancy status is also very important for many of the diseases, as well as many of the other things that are listed here: hospital admission and discharge dates, mortality, immunizations for the VPDs. Please try to obtain those immunizations for the disease you're investigating. You don't have to add measles immunizations into a pertussis case. Just the pertussis immunizations will do. There are many sources by which you can obtain that information. You can get it from the case, the parent or guardian, the provider, NJDOH. If you don't already have an account with NJDOH, please consider signing up for it. It's a great resource, a great tool. Treatment is also very important for things like meningococcal disease and pertussis to determine what the end of the infectious period may be, which then dictates what the end of an incubation period for contacts would be. disease-specific questionnaires. I already addressed that. And then a little blurb about your contacts that you identified and what actions were taken. There is a section in CDRSS that you can add close contacts into the case. But for certain things, like if you had a lot of contacts, for example, if there was a meningococcal case on a campus in a sorority house, we wouldn't expect you necessarily to add 30 people into the contact tracing section. We could talk about it with the SME and probably just put a blurb, that 30 people were notified and, of the 30, they were all prophylaxed, kind of a summary. That would be fine. But it is important to have an idea of what's happening with the close contacts. Okay, I mentioned a minute ago that you can add asymptomatic. I think a lot of folks are not super familiar with how to do that. In the signs and symptoms section, there is a little item that has add sign or symptom, and then you click on that, and then you click on the blue button, and then it gives you that drop down where you can search for a symptom that you're looking for. Asymptomatic you can add, but you can also add other signs and symptoms that may not already be defaulted in the case, but you might feel is important, so you can search and add signs and symptoms that way. Okay. The next thing is I want to talk about case classification. The VPD program uses the most current versions of case definitions as issued by the CSTE CDC. You can access the case definitions by the link on this slide. I forgot to actually put the link, but I will send that information out when I send out some information to you guys after the presentation. And it is available on our website. In the disease-specific pages, you can go there and access the link for the case definitions. We do follow those case definitions in order to classify the cases. Please don't classify a case and close it with no information. We have no way of knowing whether there's a comment, if there's no comment, how you came to the decision to classify it as confirmed or classify it as not a case, unless you leave a comment as to how you arrived at the decision. So please don't just classify it and close it. Let us know how you came to that decision. Simply a negative result lab result doesn't necessarily rule out a confirmed or probable case. And you may or may not need clinical information in addition to a laboratory result in order to be able to be a case or to not be a case. So it's really important to do that. You can also, when you're done with your case investigation, alert us to that by flipping the case to closed so that we know that you're done and that you're ready for us to review it. Just a quick word on laboratory information. We do have our Public Health and Environmental Laboratories, FEL. We work very closely with them. They do have their own site. I apologize, it's very hard to see on here. I thought I changed the font to white, but again, I will send this information out to you. A couple things I wanted to touch on. There are certain lab results that are required to be reported to us. You can see that that citation on the slide. And then as far as Neisseria meningitis and Haemophilus influenzae, isolates are required to be submitted for confirmation and serotyping within 3 days of identification. And sometimes referring to this citation is very important when you're dealing with a facility to ensure that they are submitting those isolates to our laboratory. We also do have some use of reference laboratories. We will send out to Wadsworth or CDC or Wisconsin for certain situations like measles testing and PCR, diphtheria, toxin testing, or if we need to do H. flu or NMEN serogrouping by PCR, we do use our reference laboratories for those purposes. However, permission is required prior to submitting to PHEL, and this just ensures that we're all on the same page, the facility, the locals, PHEL, and us. You can also let us know, take a quick look at the laboratory results and let us know if you see anything that looks funny. If you see something, say something. Sometimes reference ranges change or negative results maybe shouldn't be coming in, but they are. If you see something funny, just let us know. And I am basically done. I just wanted to show you a couple of resource slides. Again, I mentioned earlier on our Communicable Disease Service website, you can access the disease-specific pages by going to this link here and then looking for the disease in question. Each of our web pages do have some very good information. This is our measles page, just for example. We have a lot of resources. We do not have a chapter for measles, but we do have what would be in a chapter broken up into easy to digest great documents. We have an LHD measles investigation toolkit, which guides you through an investigation, and a lot of information, important information about laboratory specimen collection and testing. These are also some great resources that we utilize. Not only our website, but the AAP Red Book is probably the resource that I utilize the most. The CDC Manual for Surveillance of VPDs, the CDC Pink Book, both of which are accessible online. And then us, please call us. You can always reach out. We're happy to talk to you. And then the last thing that I wanted to say was, I know you're often asked for what topics that you want us to talk about. When you're requesting a topic, it would be really great if you could be as specific and descriptive as possible. Just simply requesting measles or meningitis is a little bit too broad for us. Help us give you what it is that you want to learn about, whether it be, do you want to know more about hepatitis B laboratory results? Do you want to learn more about contact tracing for meningococcal disease? Give us a little bit more of an idea of what you're specifically interested in, and that would help us target presentations to better address your needs. And that's it. I believe we're taking questions at the end, and thank you for your time.
Thank you, Liz. Next speaker.
Hello again, everyone. Again, I'm Darby McDermott, and I'm joined by Regional Epidemiologist Nicole Lamb. We will be providing an update on the hepatitis A outbreak in New Jersey and going over the necessary steps that local health departments should be taking when investigating cases of hepatitis A in their jurisdictions. Hepatitis A is an immediately reportable disease in New Jersey. It's an infectious disease of the liver caused by the hepatitis A virus. Hepatitis A virus is found in the stool of people who are infected, and it's very contagious and spread via the fecal-oral route. So when someone ingests the virus unknowingly, even in microscopic amounts, they can become infected. This can occur during close personal contact with an infected individual or through eating contaminated food or drink. Common symptoms of hepatitis A can include fever, fatigue, stomach pain, a poor appetite, gastrointestinal symptoms such as vomiting and diarrhea, dark yellow urine, and jaundice. The incubation period for hepatitis A can range from 15 to 50 days. Once symptoms begin, they can last for a long time, up to 2 months. Most people with hepatitis A do not have any chronic long-lasting illness. There is no specific medication to treat hepatitis A, so the management is supportive, and some individuals may need to be hospitalized for supportive care. While there is no specific treatment for an individual that's infected, there is a highly effective vaccine to prevent hepatitis A. In the United States, the incidence of hepatitis A decreased more than 95% between 1995 to 2011, and that's in large part due to vaccinations. But then in 2016, reported cases began increasing dramatically due to ongoing outbreaks that are across the United States. These outbreaks are spread through person-to-person contact rather than being from a common source outbreak like food or water. And certain groups are at a greater risk of becoming infected during these outbreaks. These groups include persons who use drugs, both injection and non-injection, persons experiencing homelessness or unstable housing, men who have sex with men, persons who have been or are currently incarcerated, and persons with chronic liver disease such as cirrhosis, hepatitis B, or hepatitis C. The CDC has information on their website of the hepatitis outbreaks that are occurring across the United States and reported outbreak-associated cases by state. So the map that you're seeing on this slide is from the CDC's webpage. States on the map in gray are those states whose outbreaks have been declared over, whereas states in blue have ongoing outbreaks. In New Jersey, a statewide outbreak was first identified in February of 2019. This outbreak was initially declared over in June of 2021 after having 3 consecutive 4-week periods below the New Jersey case threshold level, and that's a declaration or that's defined by the CDC. So once you've had 3 consecutive 4-week periods, can begin to consider the outbreak over. From the start of the outbreak until June of 2021, there had been 806 outbreak-associated cases in New Jersey, with 412 of those occurring, having hospitalizations, and 12 of those resulting in deaths. Cases then began to increase above the threshold levels in September of 2021, putting New Jersey back into an active outbreak status. So despite there being a few months where hepatitis A cases reported were lower, this is considered a continuation of the previous outbreak that was first identified in 2019. This slide shows an epi curve of the outbreak-associated hepatitis A cases reported in New Jersey from June 15th, 2021 to March 4th of 2022. Travel-associated hepatitis cases are not included, as these are not a part of the person-to-person outbreak in New Jersey. Criteria from the CDC was used when defining outbreak-associated cases, and it includes confirmed cases of hepatitis A in New Jersey, where the case either indicates having one or more of the identified risk factors, or doesn't indicate having a risk factor but is epidemiologically linked to a confirmed case with a risk factor, or does not have a risk factor and there's no other explanation for their illness, such as no known travel outside of the US or no known exposure to a contaminated food. During this time period, there were 79 outbreak-associated cases. October and December had the highest cases, with 18 reported cases in each of these months. Fewer cases were reported in January and February, with only 2 cases reported as having an illness onset in January and 3 in February. Here you can see the outbreak-associated case counts by county in New Jersey from that same time period, June 15th to March 4th of 2022. Of the 79 cases, 68 of those cases were hospitalized. Because many of these cases are hospitalized and prompt case investigation is necessary, it's important to note that infection preventionists or the nurses and healthcare providers may be able to assist local health departments with providing that important information to begin case investigation. When looking at the associated risk factors of these 79 cases, 14 of the cases reported having the risk factors of both drug use and homelessness or unstable housing. 22 individuals reported drug use only, and there was 1 case each that had reported a risk factor of either homelessness only, MSM, or previous incarceration. 40 had no reported risk factors, but one thing I did want to note is for those 40 individuals, due to the sensitive nature of some of these risk factors, cases may not be disclosing some of these risk factors, or that information might not have been available during the case investigation. Obtaining this information about the risk factors, however, can be very helpful when characterizing the outbreak and populations at risk and thinking about, what can be done to prevent continuation of the outbreak in these populations. So now I'll hand it over to Nicole so she can go into more detail on investigating the cases of hepatitis A.
Good morning. Thank you so much, Darby. So hepatitis A case investigation. As a reminder, for the diagnosis of hepatitis A, it is typically based on clinical symptoms as well as laboratory results. Typically, there is a hepatitis A IgM, as well as liver function tests, which include the ALT and bilirubin. Total hepatitis A antibodies are not acceptable laboratory tests. A robust surveillance system greatly helps with a rapid response. Hospitals, physicians, laboratories either send or call in lab results to local health departments. The local health departments then notify New Jersey Department of Health and local partners as needed. Some facilities are great about calling in hepatitis A cases or suspect hepatitis A cases to local health departments, and other times, especially commercial labs, will just send the laboratory results through CDRSS. In starting a prompt investigations, it is important to note the clinical characteristics. Does this case meet case definition? If so, it is really important to start gathering information about exposure and social history and interviewing the case as soon as possible. The next step would be preparing intervention. We would try to gather the source of the exposure and characterize any additional risk and if PEP or exclusion is needed. Starting with the clinical case definition. The clinical case definition for hepatitis A is an acute illness onset of any sign or symptom consistent with viral hepatitis, and jaundice or elevated total bilirubin levels greater than 3, or elevated serum ALT greater than 200, and the absence of a more likely diagnosis. It's really important to get the case to meet clinical case definition before beginning the investigation. For a case classification, in order to become a confirmed case, you need a case that meets the clinical case definition and is IgM positive, or a case that has hepatitis A virus RNA detected by NAAT, such as PCR, or a case that meets the clinical criteria and occurs in a person who has had contact with a laboratory confirmed case of hepatitis A case 2 to 6 weeks prior to illness onset. This is extremely important. I see many people starting case investigations on a case that does not meet a confirmed case status, so it's extremely important to get the case classified before starting the investigation. The identification of close contacts for post-exposure prophylaxis. When interviewing the case, it is extremely important to note the date of illness onset. We do sometimes use a proxy for illness onset, such as date of elevated LFTs, as individuals are infectious 2 weeks prior to symptom onset and up to 1 week after. It is extremely important to note activities during this infectious period in order to determine close contacts and individuals that would be recommended to receive post-exposure prophylaxis. So if an individual's symptom onset was on the 28th, we would go 2 weeks before symptom onset and a week after. It is also extremely important to note the disease-specific questionnaire in CDRSS. The DSQ can help serve as an interview tool to gather relevant exposure and risk information. If possible, this interview tool should be completed with the case. However, at times, if the case is unable to be contacted or unable to be interviewed, some of these questions can be completed using medical records or interviewing next of kin. These questions serve not only to identify risk and exposure information, but also help to determine transmission risk to other individuals. Evaluating transmission risk. When interviewing the case, it is extremely important to ask about occupation and prior work history. While food handlers have been the source of transmission in the past, it's extremely important to identify non-traditional food handlers, such as those that work in healthcare or childcare. This could include childcare workers that serve meals, prepare foods, or assist persons in their care with feeding. Some healthcare workers will be characterized in the same way as food handlers due to their risk for contact with a patient's mouth, such as providing oral care or administering oral medications. It is also important that in the context of food service, of looking at much more than the worker who is behind the line. There have been numerous instances where appreciable risk to patients was determined in the presence of a non-kitchen worker in a retail food establishment. One example of this is the shift manager of a local coffee shop. During the initial interview, the LHD identified that typically the manager does not typically have a role in food service. However, in the past week, while the individual was infectious, the shift manager did help prepare drinks barehanded due to numerous staff callouts. So it's extremely critical to interview the case during that time. For post-exposure prophylaxis. People who have been exposed to someone with hepatitis A and who have not been previously vaccinated should receive post-exposure prophylaxis or PEP. Close contacts include household contacts to a confirmed case of hepatitis A, sexual contacts to a confirmed case of hepatitis A, persons who have shared drugs with someone with hepatitis A, persons caring for someone with hepatitis A who do not use appropriate PPE or use proper hand hygiene. And the guidelines for whether vaccine or IG are indicated for PEP vary by age and health status. And the details can be found on CDC's website, which is noted there. Lastly, hepatitis A prevention. Who should be vaccinated for hepatitis A? The Advisory Committee on Immunization Practices recommends hepatitis A vaccination for the following people: all children at age 1 year, travelers to countries where hepatitis A is common, family and caregivers of adoptees from countries where hepatitis A is common, men who have sexual encounters with other men, users of illicit drugs, whether injected or not, people with unstable housing or experiencing homelessness, people with chronic or long-term liver disease, people with clotting factor disorders, people who have direct contact with others who have hepatitis A, and any person wishing to obtain immunity. And then we have provided resources. We do have a hepatitis A page on our disease topics, which can be found in this link, and that provides a great deal of information there. With that, I will hand it over to Adrian, who will be talking about multi-drug resistant organisms. Thank you.
Hi, everyone. My name is Adrienne Sherman. I am the Healthcare Associated Infections and Antimicrobial Resistance Epidemiologist at New Jersey Department of Health Communicable Disease Service. Today, I'm going to be presenting on the epidemiology and investigation of multi-drug resistant organisms, or MDROs, in the state of New Jersey. So just a brief overview of what we'll be covering today. Following this introduction, we'll do an overview of MDROs, followed by an overview of Candida auris, a particular fungal MDRO, followed by some investigation and containment of MDRO information, and a review of the available antimicrobial resistance testing resources. So first, we should start with what are MDROs? Well, antibiotic resistance is when germs, which include both bacteria and fungi, develop the ability to defeat antibiotics that are designed to kill them. So these pathogens or germs are what acquire the antimicrobial resistance, and they make treatment with antimicrobials difficult or impossible. Many MDROs can cause large yet silent outbreaks in healthcare facilities. They can have genetic mechanisms such as NDM, KPC, or OXA genes that enhance their antibiotic resistance. And these resistant genes can be shared between germs through a process called horizontal gene transfer. While colonization with MDROs poses very little risk to healthy people, it may cause illness in very sick patients, often requiring hospitalization. The patients that are at highest risk of MDRO acquisition include hospitalized patients, particularly those with prolonged stays or compromised immune systems, patients or residents with open wounds, and patients or residents with invasive devices such as indwelling catheters, central lines, tracheostomies, and mechanical ventilation. MDROs can be bacteria or fungi. Most frequently, MDROs are gram-negative bacteria. Fungal MDROs are, obviously fungi. The most notable example of fungal MDROs is Candida auris, which is an emerging multi-drug resistant yeast. C. auris is actually the first fungal pathogen to be classified as an urgent threat to public health by CDC. C. auris can cause severe infections, which would be treated with antifungals, and can spread easily between hospitalized patients and nursing home residents. On the other hand, we have bacterial MDROs, and some more commonly known bacterial MDROs include methicillin-resistant Staphylococcus aureus, or MRSA, carbapenem-resistant Pseudomonas aeruginosa, or CRPA, and vancomycin-resistant Enterococci, or VRE. Bacterial infections are treated with antibiotics and can subsequently develop antibiotic resistance. Bacterial MDROs also include carbapenemase-producing organisms, or CPOs, which are types of bacteria with inherent and acquired antimicrobial resistance. CPOs produce carbapenemases, which are enzymes that break down carbapenem antibiotics and enable the bacteria to become resistant to this class of antibiotics that are called carbapenems. That would include doripenem, ertapenem, imipenem, and meropenem, in addition to other beta-lactam antibiotics such as penicillins. CPOs carry resistance genes such as KPC, NDM, VIM, IMP, on mobile genetic elements, which can be easily spread to other bacteria, and they can also cause invasive infections associated with high rates of mortality. So when it comes to MDROs, one can be colonized or infected or both. Colonization is the presence of a microorganism on or in a host with growth and multiplication of the organism, but without interaction between the host and the organism. So there isn't clinical expression or immune response. However, colonized patients are still capable of spreading the microorganism to others and the environment despite the absence of symptoms. And as such, colonized patients can drive silent outbreaks within healthcare facilities. People can remain colonized with novel or targeted MDROs indefinitely, and there has been no effective decolonization method. Infection, on the other hand, is the replication of organisms in host tissue and results in interaction between the host and the microorganism. So there is an immune response or clinical expression, which may cause disease. Clinical infection refers to infection that results in signs and symptoms. This could be fever, malaise, inflammation, heat, or pain. Some of the most common types of clinical infections include bloodstream infections, wound infections, respiratory infections, and urinary tract infections. So there are definitely a long list of challenges that are associated with preventing and detecting multi-drug resistant organisms. A lot of them really just stem from lack of adherence to standard precautions for all patient care encounters. So standard precautions involves hand hygiene, reprocessing of shared medical equipment, environmental cleaning, appropriate use of personal protective equipment, and the like. Further, clinical cultures alone underestimate the true prevalence of MDROs. So just relying on the presentation of signs and symptoms doesn't capture all cases because it would exclude the colonized cases, which account for a notable burden of all cases. Most healthcare facilities don't perform active surveillance to identify colonized patients or residents that are asymptomatic. And there's definitely a range of accessibility in terms of access to testing. For instance, PCR testing for C. auris is not widely available through clinical or commercial labs. And PCR testing for resistance genes is also not widely available through clinical or commercial labs. Compounding this issue with prevention and detection of MDROs is the inconsistent and unreliable communication regarding MDRO status of patients or risk factors during transfers between healthcare facilities. Each patient transfer presents an opportunity for introduction into a facility and subsequent transmission. So it's really, really important that facilities are clearly communicating. A lot of the MDRO prevention strategies really tie back to standard precautions. It includes hand hygiene, ensuring proper selection and use of personal protective equipment, transmission-based precautions based on the organism at hand and the setting, proper handling, cleaning, and disinfection of shared patient care equipment, environmental cleaning and disinfection, improved inter-facility communications, including clear and consistent verbal and written communication of patient MDRO status, and antibiotic stewardship. So as I previously mentioned, the type of transmission-based precautions for MDROs vary based on the organism and the care setting. So for MDROs in acute care facilities, which includes long-term acute care, the appropriate transmission-based precaution is contact precautions. And this would be applied for patients that are suspected or confirmed to have Candida auris or other novel or targeted MDROs. Contact precautions calls for the use of gown and gloves upon entry to the patient room for all contact with the patient or their environment. So regardless of what staff is entering, whether it's patient care staff or environmental services or housekeeping, nutrition, everyone is gowning and gloving for every entry into the room. This should also be implemented during the period that test results are pending. That would indicate that a person is, suspected to have an MDRO, and just to minimize any traceback efforts, it's best to proactively implement contact precautions instead of waiting until a positive result comes back. When available, patients should be placed in a single room, and they should continue the appropriate transmission-based precautions for the entire duration of the inpatient stay and all subsequent healthcare admissions. This is particularly important for Candida auris and other carbapenem-producing organisms. Once an individual is positive, they are positive for life. So it's really important that once someone is identified as being positive, the appropriate transmission-based precautions are implemented for all subsequent healthcare admissions. Repeat testing for the purposes of clearing an individual from transmission-based precautions is not recommended. In the long-term care setting, there are two options of the appropriate transmission-based precautions. For long-term care facilities that are providing care for patients that are colonized or infected with MDROs such as C. auris, they should either implement contact precautions or enhanced barrier precautions. Contact precautions are to be implemented during an outbreak or investigation, and enhanced barrier precautions are the long-term transmission-based precaution to implement when contact precautions are not indicated. Enhanced barrier precautions, which we'll be shortening here through EBP, requires the use of gown and gloves for certain residents during high contact care activities. This is a new approach to containing the spread of MDROs in nursing home facilities. EBP essentially falls in between standard precautions and contact precautions and expands the use of PPE beyond care activities that might involve exposure to blood or bodily fluids. EBP requires the use of gown and gloves by providers during high contact resident care activities that present opportunities for transfer or spread of MDROs to staff hands and clothing. EBP should be implemented by skilled nursing facilities or long-term care facilities when a resident of the facility is identified as colonized or infected with a novel MDRO. EBP would be applied not solely to patients or residents infected or colonized with an MDRO. It would apply to them, and in addition to them, residents on the same unit as the patient colonized or infected that meet the following criteria. They have wounds or have any indwelling devices such as central lines, feeding tubes, urinary catheters, trachs, or ventilation, or have infection or colonization with a novel or targeted MDRO, and do not meet the criteria for contact precautions as outlined by CDC or facility policy. So what are high contact care activities? High contact care activities would include dressing, bathing, showering, transferring, providing hygiene, changing linens, changing briefs, assisting with toileting, wound care, device care or use, and rehabilitation services such as physical therapy, occupational therapy, speech therapy. Contact precautions can create challenges for nursing homes in trying to balance the use of PPE and room restriction with their residents' quality of life. And EBP is really intended to be more feasible and sustainable in infection prevention method when a resident is identified to have an emerging or novel MDRO. EBP reduces the restrictions placed on nursing home residents and accounts for the social and emotional needs of the residents. It allows for residents impacted by novel MDROs to be taken off of contact precautions and allows residents to leave their rooms and continue to actively engage in their social lives within the facility, since that facility is really their home, while still breaking the chain of transmission and preventing the spread of pathogens to other sick residents. We definitely encourage facilities to bundle high contact care activities to conserve PPE and reduce the amount of foot traffic that is going in and out of patient rooms. And as outlined here, there are a couple of situations in which contact precautions should be used as opposed to EBP, such as if a patient's secretions or excretions are unable to be contained, if there is suspected or documented transmission within the facility, or if a resident has an infection or other medical condition that under normal facility policy would require contact precautions. So now we're going to transition to Candida auris. As previously mentioned, C. auris is a fungal pathogen that is often resistant to multiple antifungals. It can cause serious infections in patients and is primarily healthcare associated. It typically affects long-term acute care hospitals and skilled nursing facilities that care for ventilated patients. It's become increasingly common across the United States. It was first identified in Japan in 2009, first identified in the US in 2016 in New York, and has quickly spread across the country. It can survive on surfaces for weeks if not properly cleaned and disinfected with an EPA registered List P product. And C. auris is often misidentified as other types of yeasts with common laboratory methods. Like other MDROs, such as carbapenem-resistant Enterobacterales, C. auris can cause large but silent outbreaks in healthcare facilities. Invasive infections with any Candida species can be serious and even fatal. Some reports have indicated a 30 to 70% mortality rate from individuals infected with C. auris. However, many people have died with C. auris have other serious illnesses that increased their risk of death. Strict adherence to the transmission-based precautions indicated through door signage is critical to prevent transmission of C. auris. And maintaining the appropriate transmission-based precautions for known C. auris patients has been a notable challenge, especially if healthcare providers are ordering repeat testing for a known case and then remove isolation precautions if subsequent testing comes back negative. Again, this is not the recommendation. Once a patient is identified as being positive, they should be placed and kept on either contact precautions or enhanced barrier precautions for all subsequent healthcare facility admissions. To make matters more interesting, there is no known incubation period for C. auris, so there is very, very limited data and insight on that. So why is C. auris concerning? It's often multi-drug resistant, meaning that it is resistant to multiple antifungal drugs commonly used to treat Candida infections. 90% of isolates are resistant to at least one antifungal, and 30% of isolates are resistant to at least two antifungals, which is very concerning since there are only three main classes of antifungals. We typically see resistance to azoles for the vast majority of C. auris cases in the state of New Jersey. It's also difficult to identify with standard laboratory methods, and misidentification can lead to inappropriate management. It can also easily cause outbreaks in healthcare settings. And for this reason, it's important to quickly identify C. auris in a hospitalized patient so that healthcare facilities can take precautions to stop its spread. And as previously mentioned, patients that are colonized can develop serious invasive infections. Some of the most common risk factors for C. auris colonization and infection include prolonged admissions in residents at healthcare facilities, prior admissions to healthcare facilities in states or counties with significant C. auris burden, close contact and prolonged exposure to C. auris positive individuals, which would include roommates, patients that share a bathroom, and patients that overlap on the same unit as the case without the appropriate transmission-based precautions implemented. Presence of invasive mechanical ventilation or tracheostomy and other indwelling devices are notable risk factors for C. auris acquisition, as are the presence of immunocompromising conditions, recent treatment with broad spectrum antibiotics or antifungals, and documented colonization or active infection with other MDROs. Recent healthcare that is received outside of the US is also a common risk factor for C. auris acquisition. And please note that the presence of multiple risk factors that are listed here increases an individual's risk for acquisition. So, the more indwelling devices that a hospitalized patient has, the more potential portals of entry there are for this organism to invade the microbiome. Here is an overview of the C. auris cases across the state of New Jersey. As of February 1st, there were 600 confirmed surveillance cases, 310 confirmed clinical cases, which included 48 cases that converted from colonization to clinical infection, and 22 probable clinical cases. A lot of our burden in the state of New Jersey is in the Northeast region, closest to New York City. So C. auris is a nationally notifiable disease with required reporting in many jurisdictions. New Jersey Department of Health requires antimicrobial resistant organisms to be reported, and NJDOH Communicable Disease Service responds to all reports of C. auris in New Jersey and supports prevention and containment efforts through colonization screening and point prevalence surveys, confirmatory testing and antimicrobial susceptibility testing, infection prevention and control guidance, and educational outreach. So now we're going to go into a quick overview of the investigation and containment of multi-drug resistant organisms. And we'll start by defining novel and targeted MDROs. So CDC defined novel or targeted MDROs back in July of 2019 and includes pan-resistant or non-susceptible organisms, carbapenemase producing Enterobacterales, carbapenemase producing Pseudomonas species, carbapenemase producing Acinetobacter baumannii, and Candida auris. Novel or targeted MDROs are essentially new and emerging MDROs. The epidemiology of novel and targeted MDROs vary greatly by geographic region, and historically many of these have been associated with receipt of healthcare services abroad, but in recent years, these novel MDROs have spread notably throughout the world and the US. A lot of these newer, more resistant organisms are able to take advantage of transmission opportunities that can result from even the slightest infection control breach, such as not washing your hands after coming in contact with the patient's care environment and before leaving the patient room. And pictured here is the CDC interim guidance document to guide public health officials in MDRO containment responses, which pretty much provides the framework for how we go about investigating and containing outbreaks and cases of novel or targeted MDROs. There are a couple of organisms that we don't necessarily respond to based on local epidemiology unless transmission is suspected, because these organisms are considered to be endemic or nearly endemic. Some of them include some carbapenem-resistant Enterobacterales that don't have carbapenemase genes, such as KPC, NDM, VIM, any of those. C. difficile, extended spectrum beta-lactamase producing Enterobacterales or ESBLs, Klebsiella pneumonia carbapenemase producing organisms, methicillin-resistant Staphylococcus aureus, OXA23 carbapenem-resistant Acinetobacter baumannii or CRAB, vancomycin intermediate Staphylococcus aureus, and vancomycin-resistant Enterobacterales. Regardless of whether the organism is endemic or not, all cases of carbapenem-resistant organisms should be reported to New Jersey Department of Health Communicable Disease Service through the multi-drug resistant organism case report form. So this is an overview of the MDRO containment strategy. It's a systematic public health response to slow the spread of emerging antimicrobial resistance. It really starts with detection, which is often responding to a single case. We then transition to infection control through either remote or on-site assessment of infection prevention and control policies and practices, followed by contact screening. We'll conduct case traceback and colonization screening of potentially exposed contacts. And these last two steps essentially repeat, and there'll be regular infection control assessments and screening or point prevalence surveys, PPSs, until transmission has stopped. Depending on the identified pathogen or resistance mechanism and the transmission-based precautions in place, the colonization screening may be recommended for roommates of the case patient or other patients that had shared time on the unit. Some of the common infection prevention and control challenges that we identify through AR containment responses include gaps in performing hand hygiene, limited access to alcohol-based hand rubs inside and outside of patient rooms, missed opportunities for appropriate donning and doffing of PPE, inadequate cleaning and disinfection of equipment that are shared between patients or residents, insufficient environmental cleaning practices to reduce environmental contamination, and limited access to PPE and lack of appropriate transmission-based precautions. The initial containment response goals include identifying affected patients, ensuring appropriate control measures are promptly implemented to control further spread, determining if transmission and dissemination is occurring, and characterizing the organism or mechanism in order to guide further response actions. Initial response measures are common across all three tiers. So the initial steps, identification of the case. The case could be independently identified by healthcare facilities, clinical labs, other public health laboratories, or through the state AR surveillance program. Once they're identified, cases may be reported to local health departments, which would require subsequent reporting to CDS. MDROs, including CORIS, are not currently reported or tracked through CDRSS. So we are very reliant on the awareness and participation of LHDs and facilities to make sure that all of these cases are appropriately reported and identified and investigated if appropriate. Under report receiving, we ask for digital completion and submission of the New Jersey Department of Health case report form. There's a case report form that's specific to Candida auris, and then there's a less specific general MDRO case report form that we ask to be completed by the healthcare facility where the case was identified. We also ask for a copy of the laboratory results. And as I mentioned, local health departments can play a really important role in facilitating this information. At the facility level, CDS contacts the facility regarding the MDRO case to identify if the case is currently present at that facility, establish a point of contact at that facility, provide basic education, conduct a healthcare investigation, a contact investigation, and provide infection prevention and control recommendations. This goes through a little bit of the tier-specific response activities. The healthcare investigation usually involves collecting patients' healthcare exposures prior to and after specimen collection, collecting patients' medical history, and collecting travel and healthcare history. The contact investigations, they're similarly always conducted regardless of tier. It typically involves screening of healthcare roommates and may involve broader screening of other healthcare contacts through point prevalence surveys. Clinical laboratory prospective and retrospective surveillance. We ask that clinical laboratories perform a lab look back for the previous 3 months and see if they find similar organisms. Similarly, we also recommend doing prospective surveillance and that should occur for at least 3 months after identification of the index patient or 3 months after the last case is identified.
Hi, Adrian. Are we near the end here? We need to wrap it up and move along.
Yes, we've got about 2 slides left.
Okay.
So just a quick overview of some of the lab resources that are available to you all. We provide routine testing for carbapenem-resistant Enterobacterales and Pseudomonas aeruginosa through Public Health Environmental Lab, and there is required paperwork for that, so please be aware of that. And through CDC's Antimicrobial Resistance Lab Network, We are able to provide testing for carbapenem-resistant Acinetobacter species, colonization screening for Candida auris and carbapenem maize-producing organisms. So feel free to reach out to us if you feel that any of that is indicated or necessary for facilities in your jurisdiction. And here's our contact information. And that's it.
Thank you. Ryan, can we go back to the program update slides? Kim Cervantes, first speaker.
Yes. Good morning, everyone. Hope you can hear me, and I want to apologize again for the technology issues. I actually just found out that no one is actually seeing these slides, so hopefully you have printed those out from NJLMN. If so, we're on the slide that starts with the little house. And I'm not sure. Yeah. So maybe someone can advance the slides on the webinar for me. Here we are. Okay, so the little house, I'm just going to give some brief updates on vector-borne disease. And again, I'm not going to worry about the webinar, so if someone can advance my slides for those of you that are looking, I'm going to start with Lyme disease. We're on the slide with the big tick. And just wanted my public service announcement for today is that ticks are already out. So be sure to check yourself and your dogs if you've been outside in grassy or woody areas. Most of you know we have a lot of Lyme disease in New Jersey. And it's a huge burden for many of you at the local health department level. We get over 15,000 reports of Lyme disease every year. And we know we have a lot of Lyme disease. We know we're a high incidence state. So doing that detailed follow-up is not providing us with any meaningful information at this point. So from a high incidence state perspective, the goal of Lyme disease surveillance is really to sustainably monitor the burden of Lyme disease and then monitor the long-term trends, because we already know our population is at great risk. So hopefully most of you have seen, we sent a links message that for 2022, we have a new surveillance case definition where New Jersey, as other high incidence states, will only be doing laboratory only surveillance. That basically means that Lyme disease reports no longer need to be investigated and followed up with healthcare partners to get that clinical picture. There's a lot of benefits to doing this. It helps us compare what's going on among the other high incidence states, and we're hoping that it could free up some resources at the local health department level that maybe instead could be focused on outreach and prevention. From a surveillance standpoint, all of the New Jersey Lyme disease cases will be reported as probables, and we are incorporating some additional data sources to kind of bolster the surveillance with the new approach. Next slide. There are other changes to the Lyme disease case definition that I won't go over in too much detail. It is available online. Did want to mention quickly, there are some interesting prevention strategies coming down the pike. There is a Lyme disease vaccine in the pipeline. The phase 2 trials for that, for this particular Pfizer vaccine are expected later this year. Phase 3 between 2022 and 24, which means a vaccine could be licensed as soon as late 2024 or 2025. There's also a purified monoclonal antibody treatment called PrEP, which is also in the pipeline. This is passive immunity, so they're thinking of a 1 injection per tick season approach. That PrEP is also in clinical trials. Phase 1 is expected this year. Phase 2 and 3 will probably be a combined trial with the administration prior to the 2023 season, and similar to the vaccine, could be licensed as soon as late 2024. And then tick control, the CDC is supporting a lot of research efforts to come up with tick control options that either homeowners can use or can be used at a larger scale on public lands. So as these different preventive approaches come on board, our human surveillance may need to adapt. Next slide. wanted to talk briefly about alpha-gal. Alpha-gal is a sugar molecule. It's found in many mammals, including a lot of meat products that people eat. So it's in beef and pork, venison. Most importantly, it is not found in people. It is also not found in fish or birds or reptiles. Next slide. Alpha-gal is also contained in several pharmaceutical products. So it's in certain medications. It's also in a lot of vaccines. Next slide. So alpha-gal syndrome is also known as red meat allergy. It's basically an allergic or can be life-threatening reaction to alpha-gal. Unlike most food allergies, symptoms are delayed, usually 2 to 3 hours after consumption. Hives and anaphylaxis are very common with alpha-gal syndrome, and in the United States, it has been associated with the Lone Star tick. Basically, the bite of the Lone Star tick can induce IgE antibodies, which then sensitizes you to subsequent exposures to alpha-gal, for example, when you have a steak. So preventing tick bites is a main strategy to prevent alpha-gal syndrome. Next slide. On the investigation side, I just wanted to highlight how important it is for vector-borne diseases to collect information on fever. It is required for almost all of our diseases in order to classify cases appropriately. And the problem is we get a lot of our information on vector-borne disease cases from a healthcare provider, which is perfectly fine. But if the patient doesn't have a fever on the day they happen to go see their doctor, then the doctor will report no fever. So we do ask that if the healthcare provider says there was no fever, that a patient interview be conducted to really ask if the person had a fever during the course of their illness. Next slide. Another thing that's really important for a lot of vector-borne diseases is asking questions about blood donation and blood transfusion. These are obviously rare forms of getting these diseases, but they do happen. So I put up some of the preliminary data from 2021, some of the diseases that we ask about blood donation and transfusion, and the percentage that those questions have been completed. So overall, doing pretty well. I mean, over about 3/4 of the cases have that question documented in CDRSS for Babesia, Borrelia miyamotoi, West Nile virus, enterocolitis, anaplasma. A little bit less, I was a little surprised for malaria and less than that for dengue. But just a reminder, if there are questions in the disease-specific questionnaires on blood donation, transfusion, there are also questions about organ transplant, that those are important because we do track those back with the blood collection centers. Next slide. Wanted to just give a brief update. Up till now, up to 2021, the state hadn't had a statewide tick surveillance program. Many of you probably are familiar with your mosquito control counterparts. But we have started some statewide activities starting in 2018 under the leadership of Rutgers. And then moving on to 2021, we are working with county mosquito control agencies in the shaded counties on the map. Have started to collect ticks. They will be tested for pathogens, and there'll be more coming for that. But just wanted to let you know that tick surveillance is now going on. Next slide. You can look at these maps a little bit later on, but basically this is showing where different tick species are found, either the lighter colors where they've been reported or the darker colors where there's established tick populations. I mentioned alpha-gal. The second map in orange is the Lone Star tick. So you can see it's really spread pretty much through central and South Jersey, but there have been reports up in the northwest part of the state as well. So that's something to be looking at. Next slide. For 2021, this is basically just the collection data, just to give you an idea. Most of the ticks were collected in May and November, which correspond to the peak nymphal and adult seasons of Ixodes scapularis, or the deer tick. There were ticks collected from 60 sites across the state. Over 1,000 ticks have been collected, and testing for different tick-borne diseases is underway. Next slide. This is just a little bit of the approach for tick surveillance in 2022, but I'll jump all the way to number 5 of being probably of most interest to you at the local level is that we are going to be working on how to share this data with you and other partners and perhaps the public, as well as a communication strategy for how to discuss tick surveillance data with the public and what actions people should take. Next slide. Super quick, I can't do a vector-borne disease update without mentioning West Nile virus. So last year, I just want to say that was a really busy year for West Nile. It was our 3rd busiest season in terms of human cases. There were 5 deaths. It was a lot of activity. And if you sort of look at this slide, I know it's busy. The red years are sort of our epidemic years. The blue years are our endemic years. So if I was a betting person, I might bet that 2022 could be a lower year in terms of West Nile. But now that I've said that, I will probably be wrong. Next slide. I'm going to skip this one. Let's go to the next slide. This is just a picture of West Nile nationally for 2021. Which you can kind of see New Jersey there in the circle. We had a very, very busy year, but we seem to be one of the only states in the region that did, which why that is certainly a puzzle, but it could mean another busy year or it might not. Next slide. And let's see, let's go to the next slide. Kind of wrap up here. Just one thing I wanted everyone to know for arboviral testing. We have been doing some confirmatory testing for chikungunya and West Nile virus. We're going to continue that in 2022. And you can see the criteria there. And with that, I'm going to have to wrap up with a lack of time, but our group emails on the next slide. Thank you.
Kelly?
Kelly, you're muted if you're speaking.
Sorry, here I am. Good morning, everyone. My name is Kelly McLaughlin, and I am the team lead as well as one of the health educators for Project First Line here at the Department of Health. And I just wanted to take a few minutes of your time to give a quick introduction to Project First Line because this is still a relatively new program that maybe some of you are familiar with, but maybe not all of you. So I just wanted to take some time to tell you a little bit more about the services that we currently offer. So Project First Line is a CDC-funded training collaborative, and New Jersey Department of Health is one of its many partners. Every state health department in the United States is participating in Project First Line. And really what the mission of Project First Line is that with its partners is to help prevent the spread of infectious diseases in healthcare settings. The vision of Project First Line is also really to help empower every frontline healthcare worker with the knowledge and confidence to understand infection control principles and protocols, so they can feel that they can confidently apply these practices to protect themselves, their facilities, their families, and their communities. And the goals of Project First Line are to offer multi-platform training events, whether that's in person or virtual, to be able to cover a variety of infection prevention and control training topics that can include a diverse group of frontline healthcare workers. So we're really not limited in terms of the types of healthcare workers that we're trying to reach. And with that, we're trying to expand our reach to include non-clinical support staff in healthcare settings. That may include your environmental services workers, your dietary workers, but we're also trying to reach another targeted audience, which is students that are studying in the healthcare fields, because we're finding that it is just as equally important to prepare the next generation of healthcare workers to give them the skills that they need to prevent infections in the workplace once they do finally enter the workforce. We also want to be able to provide this training, put more of an emphasis on long-term care facilities as well as acute care facilities, because what we're found during the pandemic is that these were facilities that were particularly hit the hardest during COVID-19. So we're really trying to emphasize on those sites as well. And then engagement is also just as important with Project First Line. So while we are busy offering trainings to frontline healthcare workers, what's also important with our grant is also being able to promote Project First Line, the program, the topics that we cover, but also being able to provide brief opportunities to provide health education through social media. So social media is a big component of our program as well. As I'm sure you're aware, it's a great way to get the message out about a program, advertise a training, but also to still educate your targeted audience through concise messaging. So these are the available infection control trainings that we offer. I know that that's really tiny, I do apologize, but we currently offer 15 different topics. There were new topics that were just dropped as of last week by the CDC that we can add to our training arsenal. So you can see that these are the different topics that we offer here. Some of you may have participated in some of our virtual trainings that we recently had done. We had done presentations on gowns and gloves, environmental cleaning and disinfection, and the asymptomatic spread of COVID-19. But we can offer the rest of these topics provided here. Tell you a little bit more about our training topics. So again, we can offer our trainings in person as well as virtual. We have the great fortune to be working with 4 sub-grantees that we have. And some are offering just in person, most are still offering virtual. Internally, the health educators here, we're offering both types. And what's neat about these trainings is that healthcare facilities can decide what topics they want their staff to learn more about. Maybe that's based on what they feel that their facility might need. So they can pick one topic, they can pick multiple topics. And what's unique about Project First Line is that each topic is able to be modified to be completed in as short as 10 minutes or as long as 60 minutes. So that there's a lot of flexibility that goes with this program that makes it unique to be able to adapt to the different time constraints that most healthcare facilities have for various reasons. And Project First Line also has well over 30 infection control educational videos that cover the training topics that I mentioned in the previous slide in further detail. Something I thought that might be of interest to everyone here is that last year we had completed a learning needs assessment that we had sent out statewide to reach as many frontline healthcare workers as possible to get an idea of what the gaps in knowledge are with infection prevention and control. So this is just some very preliminary data. Again, it's so small and I do apologize for that. But the biggest takeaway here is that of all the IPC topics that were listed on our learning needs assessment, healthcare, you can see on the left that most healthcare workers felt that they needed more education and training around the topic of crisis standards of care. whereas the least requested training topic was hand hygiene. Not necessarily surprising, since that can be seen as a very elementary type of topic when it comes to infection control. And as of March 4th, we had over 1,100 frontline healthcare workers participate in this learning needs assessment. So just so I wanted to share, I did mention that we do have 4 sub-grantees that are currently working on Project First Line with us. One of them is the New Jersey Association of County and City Health Officials, so it's NJDOH, and the trainings that they're currently offering, it's a web-based 2-day Train the Trainer course that's targeted specifically to local health department staff. Maybe you have heard about NJDOH's trainings already, maybe you haven't, and if you haven't, this is just an opportunity for, again, to know that these trainings are available to you as local health departments, and to be able to get more information about the Train the Trainer course that NJDOH is offering. You can contact Michael Hodges. He is spearheading Project First Line through NJDOH, and his contact information is down below. I can share with you that they are offering CEs, which is always an exciting incentive. I know for a fact that they are offering CHES and MCHES credits, 8 credits to be exact. So that's a half a year's worth of credits for the CHES and MCHES folks on this call. Again, to get more information about it, you can contact Michael with his info down below. And just wrapping up, how you can support Project First Line is help get the word out about Project First Line and promote it. All of our Project First Line social media posts are posted on the New Jersey Department of Health social media channels. We do not have our own unique social media. We post weekly, so simply just following the New Jersey Department of Health on social media, and when you see our posts, and share them on your social media pages, that would be one great way to help. You can also sign up for our newsletter. You can sign up for a training or help host a training through the help of NJDOH, and you can also take part in the development and delivery of future trainings. I know it's really small here, but this is our Project First Line landing page on the on the New Jersey Department of Health website. For your convenience, there's a QR code, and a direct link is tinyurl.com/PFLNJ to get more information about our program and some of the current programming that we offer, such as our college tour. Again, you can follow us on social media. We do not have our own social media pages. Everything that we post is through the Department of Health, but we're on Twitter, Facebook, Instagram, and LinkedIn. You can also email us directly for additional questions at cds.ic.pfl@doh.nj.gov. For your convenience, you can visit our website with the QR code, and you can join our email list with the QR code to your right. Thank you. I'm going to pass it over to Deepa.
Make sure that you can hear me.
Yes, we can hear you.
Yes. Good morning, everyone. I'm Deepam Thomas, and I'm the Foodborne and Respiratory Illness Unit Coordinator. Today, I'm going to share a quick situational update from both worlds. Since you cannot see me advancing slides, I'll try my best to indicate as I move ahead so you can follow along on your slide deck. So let's start off with influenza. The overall goals of conducting influenza surveillance are what's listed here, and in interest of time, I'm not going to read them. But the triangle on this side is to show the influenza burden and to understand that when we talk about influenza surveillance, our numbers are just an estimate. So we cannot count every case of disease, and many are not seen by a provider or tested, and that's at the very bottom of this pyramid. And this is just to emphasize that what we do track is only a portion of the true influenza burden. Next slide. For reporting, just a reminder, influenza is a lab reportable condition per regulation, and we only get positives in CDRSS. The screenshot on the right is the memo that gets updated every season, and it describes reporting requirements. and also lives on the flu page on the NJDOH website. Next slide. Now, because it's not possible to count all cases of influenza, we use ILI, which is influenza-like illness, as a proxy for disease. And the definition for ILI is very broad. So it's not every positive test, but rather a set of symptoms. So it's fever, cough, and our sore throat. And when we use this for surveillance, there is a possibility of picking up other respiratory viruses which mimic flu. But in order to better characterize, we then combine it with lab data, and then that provides a good representation of the circulation. And this is probably a slide you've seen before, so I'll not get into the details, but it is a good summary of all the data that goes into the weekly reports that you see. Next slide. As far as investigation goes, there is no investigation necessary on any individual flu positive. So unless the case meets definition for a severe or fatal case of pediatric influenza, novel flu, or if it's part of an outbreak. The screenshots on the right are those that are the memo and the guide for pediatric flu investigation. There is really no investigation needed. Next slide. Most of you have already probably picked up from media or from the weekly reports that we send out or from CDC's website that flu activity is going up again. And these are just snapshots from the week before last, but we are seeing steady increases nationally and in New Jersey. This is the next slide again. This is from MMWR week 9. We moved up another region to moderate last week, and those weekly reports can again be found on our website besides the links messages if you haven't signed up for them. Next slide. As you can see, our report formats have changed this season. We have received very encouraging feedback from many of you. But besides the overall formatting and the page that you just saw, which was new, we've added a highlight section at the top and a 5-year activity comparison to see where we are for the same week activity-wise compared to previous seasons. And this also allows you to see how the pandemic years compare. Next slide. Now, this is a brand new chart. When RSV fled between seasons, seasonal comparisons showing circulation was included in a links message that was sent out to allow for prophylaxis ordering and administration. And this was very much liked by a couple of pediatricians who reached out to us. So we added this to our weekly report. So in addition to the pie charts that represent non-flu, non-COVID respiratory data from CDC's NERS platform, and this is from New Jersey facilities that have enrolled, there is in addition this chart that kind of compares previous seasons. Next slide. This is the significant change that CDC did this year, this season. So they did away with the CST activity levels. And so activity levels are now just broken down into 3 main categories. So it's just low, moderate, high, and the low and the moderate do not get broken down any further. Next slide. And as I mentioned before, besides pediatric flu cases, another scenario that requires individual case novel strains of influenza, and currently we are seeing circulations of highly pathogenic avian influenza. Wild birds can carry these viruses without getting sick, but domestic poultry can get very sick and can often die. Now, avian influenza can be classified into 2 main categories. So low pathogenic avian influenza, LPAI, or highly pathogenic avian influenza, HPAI. And the recent detections of HPAI is influenza A H5N1 virus. And this is one such subtype of HPAI. Now, the concerns with this is really rapid spread, death among poultry, economic impact this can have, and of course, the transmission risk to humans. Next slide. As of March 18th, 2022, H5N1 bird flu viruses have been found in wild birds in 24 states, and this includes New Jersey, and in commercial and backyard poultry in 17 states, and New Jersey is not one of them. This poses a low risk to the health of the general public. However, rare human infections are possible. So this can happen in people with exposures involving prolonged, unprotected, close contact with infected birds, or then their contaminated environments. And the CDC infographic on the right explains transmission. So the US Department of Interior and USDA are the lead federal departments for outbreak investigation and control in wild birds, and USDA APHIS is the lead agency for activities and outbreak control in domestic birds. CDC is still taking the lead on human health, and they are working very closely with USDA to monitor human infections in people who have had H5N1 bird flu virus exposures, and they would be working very closely with states on surveillance. So no human infections with any HPAI has ever been detected to date in the United States. And typically these would present with respiratory signs and symptoms. But from a monitoring perspective, when we are notified of any New Jersey residents who've had contact with infected birds, we will then work very closely with the respective local health department to monitor symptoms for 10 days from their last exposure. And testing, treatment, chemoprophylaxis guidance is all available on both the NJDOH and CDC website. Next slide. This slide includes links to both state and CDC websites. And I'm just going to move ahead in the interest of time. I'm just going to go ahead and provide a quick foodborne surveillance and outbreak situational update. These next two slides really explain why foodborne illnesses investigations are so important. All too familiar lines. CDC estimates each year roughly 1 in 6 Americans, or 128,000 are hospitalized, 3,000 die of foodborne illnesses. The next one is an estimate, and this was calculated by CDC using a model with 31 pathogens, and the range of approximately $600 to $3,000 and an average of $1,600 spent on every foodborne illness. Next slide. Now, this highlighted agents list are individual reportable diarrheal diseases in New Jersey, and of these, E. coli, listeriosis, typhoid, paratyphoid fever, vibriosis, and cyclosporiasis all have required case report forms associated with them, and CDC calculates metrics on state submission. So we urge you to continue to send these in after you've completed the questionnaire through a case interview. Next slide. Very similar to case investigations that Liz outlined, after a case gets reported and you've looked through lab testing, determined the case classifications, while clinical information can be confirmed and gathered from a provider, I would also like to echo that the information gathered on foodborne case illness investigations should be through a case patient interview with the appropriate CRF or the case report form. And all of these diseases have sources of infection and risk factors section within CDRSS. So that's your place to document exposures. Make sure, besides the critical details, that you're updating CDRSS and sending those required CRFs in. And to make access easy, except for our heavy volume diseases caused by Campylobacter and non-typhoidal Salmonella, our foodborne team will continue to include links to the investigation checklist and the case report form in every case. So every case of Listeria, typhoid, and so on and so forth will include these links for easy investigation. Besides routine surveillance, I also want to quickly highlight 2 investigations that CDC had web postings on recently. First is the Chronobacter sakazaki illnesses linked to powdered formula. Chronobacter sakazaki formerly was known as Enterobacter sakazaki, and it's found naturally in the environment. It can also live in dry foods, so powdered infant formula, powdered milk, etc., and can cause sepsis or meningitis. This is not a reportable condition in any state besides Minnesota, so when the recall was issued, we sent out a links message pretty much reiterating the CDC and FDA action items, highlighting symptoms, and more importantly, shared a surveillance case report form that we had developed. So if there were calls that came in to a local health department and to you, that information could be systematically collected. Nationally, there have been 4 illnesses from 3 states, 4 hospitalizations and 2 deaths. Thankfully, New Jersey has not received any reports of illness so far. Next slide. This is the last investigation I wanted to quickly bring to your attention, and this is the multi-state Listeria outbreak linked to packaged salads. This has a total of 10 illnesses in 8 states, and you can see the severity. There are 10 hospitalizations, 1 death. New Jersey has 2 cases in this outbreak. As I mentioned before, this is where the prompt investigation with the case report form on your part becomes crucial, because the quicker the interview gets completed, the more the case patient is able to recollect, and the quicker we can share this information back with CDC, work on tracebacks with FDA, and then if those common exposures are identified, the quicker the recall can be issued. So further illnesses can be prevented. So all of your work is vital. We truly greatly appreciate it. Keep up the great work and keep sending those exposures and the CRFs in. And this is the final slide. I've included contact information for both our teams on the last slide. Feel free to reach out either through the main line, via phone call, or any of the email IDs listed here. Thank you.
Okay, just need my slides. All right. Good morning, everybody. Good morning from the Hepatitis C team. We're going to take a few minutes to update everyone on the surveillance performance metrics being monitored by CDC for viral hepatitis. We're going to focus primarily on hepatitis C, but a little bit of Hep B as well. I'm going to start, and then I'm going to see if I can patch Bernice Carr in to finish up the presentation. CDC is very interested in certain indicators from viral hepatitis surveillance. These are all integral to prevention and control of disease, as well as health equity. There are three primary categories: documentation of demographics, documentation of risk factors, and timeliness. Timeliness refers to cases being closed within 90 days of being entered into CDRSS. And each of these has a goal of 90%. So how did we do in 2021? 2021 case closeout is not complete, so these numbers refer to whatever was submitted by the end of the year. Demographic completeness is pretty good, at or above 90% goal for everything except race and ethnicity. Acute Hep C is above 90% at 92%, but acute Hep B and chronic Hep C need some work. So we ask that you please make an effort to complete these sections during case investigation. The next primary area of focus is risk factors, and we know that documentation of risk factors has historically been a challenge. This graph doesn't break down individual risk factors, it just refers to cases with any risk factor at all documented. We're at 60% for acute Hep B and only 50% for acute Hep C. In order for risk factors to be counted, they need to be documented in the risk factor section with the drop-down boxes. And that is also documented with either a yes or a no. So even if it's mentioned in the comments section, the drop-down boxes need to be used in order for the risk factor to be counted. Although the risk factor list in CDRSS for hepatitis C is very lengthy, there are 12 specific risk factors that are of the most interest to the CDC. And these 12 should be answered with a yes or a no. If it's left blank, it's going to result in an incomplete status. And again, the goal is 90% completion. So moving forward, we're going to review those 12 risk factors, and we're going to see if we can move this over to Bernice to finish. Bernice, are you able to unmute? Let's see.
If not, in the interest of time, Mary Ellen, can you just
keep going?
moving?
Okay.
Yes, please.
Yeah. All right, so I'll do that. Right. So what are those particular risk factors? CDC refers to them as risk behaviors. In CDRSS, it says risk factor. So this slide and the next show the 12 risk behaviors that CDC is most interested in and what is the closest match in CDRSS. For most, the CDRSS risk factor match to the CDC risk behavior is obvious, but there are a few that require some explanation. And all of these should be answered with a yes or no. So sexual contact, there are actually two responses. First is, did the patient have exposure to an HCV infectious person? And then the second question is asking what type of exposure, and you select sexual partners. For household contact, again, there are two. Did the patient have exposure to an HCV infectious person? And then what is the type? And you answer, select household members, non-sexual. For multiple sex partners, that's not an option in CDRSS. So you would go to where it asks the number of female sex partners or the number of male sex partners, no. And in the attributes, you respond with greater than 2 to indicate multiple. The next, dialysis, transplant, needle stick, those are pretty self-explanatory. They ask, CDC is interested in occupational exposure to blood. That's not worded exactly the same way in CDRSS. In CDRSS, you would select, is the patient a healthcare worker, public safety worker, veteran? And they're also interested in international travel, but that's for hepatitis B only. They're not interested in that for hep C. Okay, so timeliness. All right, timeliness. The third performance monitor looks for cases closed and submitted to CDC within 90 days, and the start date is the date the case was entered into CDRSS. As you can see, we have some opportunities for improvement, and hopefully we'll get closer to our target over time as things settle down. Right now, we're at 36% for acute hep C and 30% for chronic hep C. Remember that for non-priority cases, a single attempt at getting information is all that's required, if that is all that resources allow. The case can be classified according to lab values, so there's no need to hang on to non-priority confirmed cases for more than 90 days if you're not getting a response. You can just update the demographics and risk factors to the best of your ability with whatever information you have and classify the case with the lab values available. If you need a reminder about what is a non-priority versus a priority case, you can look at the viral hepatitis page on the website and review the updated disease chapter. All right, so we're going to wrap this up. Coming soon, to make it easier to track your progress, on the DOH website, there's going to be an interactive dashboard with case completion metrics, where the local health departments are going to be able to monitor for themselves. There will be a general dashboard for all communicable diseases with specific metrics for viral hepatitis based on the CDC requests. And there's going to be more information about that coming out in the next weeks and months. If you have any questions, you can reach out to me or to Bernice Carr. Most of you know how to find us, and we'll be happy to answer your questions.
Thank you. Just a quick update. My sincere apology for the technical difficulties today. And I know that NJDOH are working really closely to find out, what was the main technical issues. So I know there is no time for questions, but I have two options for you guys to send us questions. One option is to email your regional EBI, and we will forward that to the speakers and get you the answer that you want. And the second option is we will send you an evaluation link, and we can send you our general email that is monitored by us, and we can get questions in this email. I will let Ryan from NJDOH to talk about the credit, how it's going to be handled. Thanks. Thank you, sir. Thanks, everyone.
Thank you. Sharif, did you want me to clarify the process?
Yes,
for
please.
the survey?
Yes,
okay,
please.
so just to let everyone know, we will be sending out shortly after we close this session an email with the survey link to everyone who is registered to attend the webinar. That email will also include the recording of today's event. So if there's anybody in your group who wasn't able to get on the call and views the survey, views the presentation later and completes the survey with the attestation statement, then they will receive credit as well.
Thank you.
Okay.
Thanks, Ryan, and thanks, everyone. Have a great day. Thank you.